Tumati Shivapriya? Yeah, she is here.
Okay.
Good morning, everyone. My topic is on Tersons syndrome, comprehensive review and clinical analysis. Tersons syndrome refers to oculocerebral syndrome with hemorrhage in vitreous subhyaloid subretinal space, even beneath ILM, associated with intracerebral bleeding. It is reported in 17 to 28 cases of SAH and 9.1% cases of intracerebral hemorrhage. It is a prospective study of 5 cases present to our tertiary center. We have diagnosis is primarily clinical with fundus imaging, OCT and CT. Pathogenesis, Tersons syndrome is described most commonly in subarachnoid hemorrhages due to ruptured cerebral aneurysms. Other causes are strangulation, trauma, hypertension, tumor, etc. Main possible pathophysiology was transmission of intracerebral blood through optic nerve sheath and then thereby increasing the intracranial pressure and rapid effusion of CSF through this optic nerve sheath and then compressing the central retinal vein and then rupture of thin vessels from inertial injury and thereby hemorrhage. In case 1, 21-year-old male patient presented after RTA. He was admitted in hospital. After regaining consciousness, he complained of diminution of vision. Fundus imaging and B-scan revealed vitreous hemorrhage in both eyes. Patient was observed for 6 months. Right eye vitrectomy was done, and left eye after 6 months spontaneous resolution was seen. Whereas in case 2, 45-year-old presented with RTA, he had brief loss of consciousness and he had SAH and SDH, where he was admitted in NIMHANS and he was treated for right frontotemporal parietal decompressive craniectomy with evacuation of acute SDH, and he was put on supportive care. After extubating, patient had diminution of vision. On fundus examination and B scan, there was vitreous hemorrhage in both eyes. Patient had to be treated in a center. Both eyes vitrectomy was done. Whereas in case 3, 24-year-old patient with history of RTA with CT brain suggestive of EDH. On examination, right eye showed corneal ulcer with proptosis with periorbital edema and ecchymosis, whereas left eye was very much normal. And fundus examination showed left eye vitreous hemorrhage. On B scan, it was confirmed, and treatment, right eye temporary torsography was done. Left eye self-resorption was seen in 3 months. In fourth case, 27-year-old with RTA. On CT, he had SAH. On fundus, he had vitreous hemorrhage. Patient was observed for few months, and self-resorption was seen in 4 months. In case 5, 41-year-old patient with RTA, CT was suggestive of SAH. On fundus examination, vitreous hemorrhage with focal traction was noted. On B scan, it was confirmed, and patient was taken up for internal procedure. Discussion: the first conservative form of management would be to monitor patient for blood resorption and spontaneous visual recovery. After 3 months of monitoring blood resorption with no improvement, and in conditions like non-resolving VH in patient who has monocular or dense binocular vitreous hemorrhage associated with retinal detachment, vitrectomy is very much required. Whereas in pediatric cases who have greater risk of amblyopia, it's better to take them for early vitrectomy. Late complications of intraocular hemorrhage such as epiretinal membrane formation leading to macular pucker can also occur. Thus, early diagnosis and timely intervention minimizes disease progression and enables better rehabilitation in most of the cases. Conclusion: Tersons syndrome presents a unique clinical challenge, often serving as an indicator for underlying intracranial pathology. Though rare, intracerebral hemorrhage is associated with intraocular hemorrhage, hence screening patients of head trauma who are on supportive care, who cannot verbalize their visual loss, will help in diagnosing and intervening early. Neurological outcomes and mortality rate is 20 to 60% more worse in patients associated with intracerebral hemorrhage and Tersons syndrome than patients who have intracerebral hemorrhage alone. Thus, we can conclude that importance of making fundoscopic examination mandatory for all head injury patients to prevent permanent impairment of vision. Thank you so much. These are my references.
You said the neurological prognosis is different if you have a Tersons syndrome associated.
Yes, sir. There was a higher rate of mortality.
What could be the cause? Like why?
Disability and...
Not disability. No.
Yes.
If it were to cause Tersons syndrome, the amount of SAH and the pressure rise in the pathophysiology is so severe probably. So that is a surrogate marker, not directly related to
Not
Tersons
right.
syndrome.
Yes.
But how do you exclude? You had 5 cases. even your RTA can also produce a closed globe injury and a vitreous hemorrhage.
Yes, sir.
So any care was taken to exclude an isolated traumatic vitreous hemorrhage as a part of closed globe injury, as a part of RTA, than this? Was there anything that was done to show the pathophysiology is working in the way it has
So,
to?
all the 5 cases which I have concluded in my study, they had anterior segment was normal, and only on fundus imaging there was vitreous
No
hemorrhage.
ocular trauma,
No
whatever
ocular
cause,
trauma,
even no
sir.
closed globe
No
injury,
ocular
no lid
trauma.
edema, no ecchymosis.
Only the 4th case, other eye had ocular trauma, sir, but on fundus imaging, the right eye was normal, whereas the vitreous hemorrhage was only noted in the left eye for the 4th case. Other than that, all the other cases had normal anterior segment.
What the sir is asking is, all cases of intracerebral hemorrhage, if they have got vitreous hemorrhage, it means it is Tersons syndrome.
Yes, sir. Internal limit.
Just a diagnosis that we make, but typical Tersons syndrome has the way
predict.
that you explained. So there's a rise in the CSF pressure, it is going to strangulate the venous flow, and then it is going to cause a bleed in the vitreous cavity.
It's not necessary that we will have some anterior segment finding in case of traumatic vitreous hemorrhage. Anterior segment can be absolutely fine, and we can land up in vitreous hemorrhage maybe due to PPD, in contact of injury, etc. So that is not exactly clear-cut diagnosis.
And during the head injury, nobody looks at the eye.
Yes.
He may report to you after 2 weeks after the head injury. By then, all the
could have
anti-segment signs would have disappeared.
Yes, sir.
Yeah, she concluded that all these cases should be examined by the ophthalmologist as well. So thank you very much.
Thank you.